Hi, good afternoon, everybody. Thank you for joining us today for today's lecture. My name is Dr. Pavel Jankowski, and I'll be speaking to you about adult spinal deformity, this definition, and treatment options. My specialty is in adult and pediatric spinal deformity, and I practice at Hoag and Chalk. So let's jump right into it. So adult spinal deformity is becoming more and more common in our society today. It's often a very frequent cause of pain and disability that goes underdiagnosed in a lot of clinics. It increases with age, with the most prevalent age groups that are affected by it between the 60 to 80-year-old group. And its treatment options, especially in the past decade, have expanded. Also, our understanding of it has evolved, and new treatment options have also expanded with our knowledge. So let's first talk about some numbers here. According to 2014 U.S. Census Bureau, 54 million people were reported over the age of 65. This elderly population is expected to reach 80 million by 2050. Along with the rise in age is also the need for spinal care, including for adult degenerative spinal deformities. The demand for surgical treatment for degenerative spine diseases, including decompression, instrument infusion, and deformity correction, has increased in conjunction with it in this age group. We see here a plot from the U.S. Census Bureau, which shows the increasing age group over the next set of decades. And you can see the steady rise here in this elderly population above the age of 60. Spine disease in the elderly primarily consists of lumbar spinal stenosis, cervical spondylosis, degenerative spondylolisthesis, and spinal deformities. According to Medicare reports, new patient visits have increased over 3 million per year between 1999 and 2009. Amongst these new patient visits, one of the top 5 diagnosis codes, according to the ICD-9, was other and unspecified disorders of the back, which in this case pertains to spinal deformities. The ICD-9 has gone on to be replaced by the ICD-10, and the code for this corresponds to dorsalgia unspecified. According to Deo, who identified that lumbar fusion rates in the United States have risen drastically between the years of 1988 and 2001, the rates of lumbar fusion surgery among patients over the age of 60 increased by 230%. Adult spinal deformity has been found to increase with age as well, with rates as high as 68% in those over the age of 60. In terms of what this does to the patient, the biggest factor is that it affects the daily quality of life. It impacts one's functional limitation, it increases one's pain, and also increases one's use of analgesics and the need for different pain modalities in order to continue through daily activities. In addition to some of the functional limitations that adult spinal deformity has, it also bears a heavy psychological effect that is associated with a social stigma, depression, and anxiety. You can see here in this curve, this is the SF-36 quality of life outcome measures, and it measures different types of functional statistics, such as physical function, psychological, bodily pain, general health. And this is matched against the general U.S. population versus those with scoliosis/spinal deformities. You can see that the patients with scoliosis in red score significantly lower on this scale when matched against their age-matched cohorts. Now to give a little bit of explanation of, and to get a little better understanding of what we are talking about and why is all of this pertinent. Spinal deformity, if you simplify it down, is a ergonomic posture. It's a matter of alignment. And this alignment stems from this illustration, which is called the cone of economy, and was developed by a French deformity surgeon, Claude Dubussé. And essentially it dictates that if the head is positioned over the pelvis, this is the most ergonomic structure that one can achieve. If the head deviates forward or backward over the pelvis, there's a cascade of events that happens which leads to pain. Next, let's talk about the different types of curvatures throughout the spine. We divide the spine into 3 segments: the lumbar spine, which is the lower back, the middle part, which is the thoracic spine, and the upper spine, which is the cervical spine. Each of these 3 segments have their respective natural shapes. The lower spine, the lumbar region, has lordosis, which is a bow-shaped structure. The middle part, the thoracic spine, has a hunch, which is called a kyphosis, and it's present there to allow for the lungs to expand. In order to maintain proper alignment, it is counterbalanced by a lordosis in the cervical region. This, as we can see in the figure, on the farthest left-hand side, allows for the head to be optimally positioned over the pelvis. When there's a deviation in any one of these alignments, we can see that there is also a change in the global alignment. If there's an excessive kyphosis in the thoracic region, the head gravitates and drifts anteriorly, shifting the overall center of gravity. If the spine in the lower region is malleable and can accommodate, it'll be balanced by a hyperlordosis. However, if there's a flat back scenario, or if there's stiffness in that spine, other compensatory mechanisms have to ensue. In this case, the pelvis. The pelvis will retrovert and tilt backwards in order to allow for the patient to maintain their center of gravity over the pelvis. Once this is exhausted, they will bend their knees and also extend their ankles. Each of these compensatory measures, however, has a particular limitation, which is dictated by one's pelvic incidence. The pelvic incidence, the easiest way to think about is it's one's own individual spine fingerprint ID. Each and every one of us has their own pelvic incidence. It develops throughout the teenage years and then stays for the most part the same throughout adulthood. We see here, this picture is meant to show us a further clarification of the terms that I just discussed. The lordosis here on the far left-hand side is a bow-shaped structure. The kyphosis, which is a hunch throughout the thoracic spine in the middle, and a scoliosis refers to when we're talking about a patient from a front to a back plane. In this slide here, we can see here an illustration of spinal balance. Again, the goal is to maintain the head positioned over the pelvis. Any abnormal curvature can put the spine out of balance. When we are approaching and discussing the spine from a right to left, we're talking about the sagittal plane. When we're discussing the spine from a front to back, we're talking about the coronal plane. We see here on the left-hand side an optimally aligned spine with no type of compensatory mechanisms. The moment that the lordosis is decreased in the lower lumbar region, the pelvis will begin to retrovert and the pelvic tilt will increase. When we move over on the far right-hand side, we see a further deformity taking place, and the compensatory mechanisms, which I discussed in the previous slides, are exhausted, and the gravitational line now drifts forward. So in clinical outcome studies that have shown to validate this, in the particulars, one by Stephen Glassman out of the Leatherman Institute in Louisville, Kentucky, showed over analysis of thousands of patients that when the sagittal plane is increased forward, or another way to think about it, if the forward tilt of a patient increases, the quality of life decreases. The plots that you see here on the slide refer to the Oswestry Disability Index at the bottom, and we can see here that an increasing score, which is correlative to a negative outcome, increases with the increase in sagittal alignment. The SF-12 score decreases, which is also correlated to a negative outcome. To put this into further clinical perspective, this is a patient with a sagittal imbalance and a gravitational line that has shifted anteriorly in relation to her pelvis. So now let's go over the different types of spinal deformities that are present in adults. These are subclassified into idiopathic, degenerative, and iatrogenic. In idiopathic scoliosis, the best way to think about it is that this is a scoliosis that has developed at some point during the teenage years or young adulthood and either did not require any type of surgical intervention, was treated through conservative measures, or was underdiagnosed. However, when we look at pediatrics, we're primarily concerned with bone growth and when the patient has stopped their level of bone maturity. However, once they graduate from the pediatric clinics and they enter into the adult clinics, their spine continues to degenerate. With the degeneration also is an increase in curvature. This spine will continue to progress in its curvature anywhere from 1 to 3 degrees by the latest clinical studies. Also, another way to identify adult idiopathic scoliosis, like idiopathic and pediatric scoliosis, that it has a compensatory and a major curve. In terms of degenerative scoliosis, it's a progressive and asymmetrical degenerative changes within the discs and the facets. Degeneration processes that happen in our spines do not occur in a symmetrical fashion, but rather are dictated by other forces. And therefore, as you can see here in this picture in the lumbar spine region, an asymmetry happens, which allows for a curve to be either to the left or to the right. Also in this picture on the right-hand side is really important, is a sagittal imbalance takes shape. It's when a scoliosis takes place and a deformity takes place, we look at it as a two-dimensional structure. However, it really is a three-dimensional pathology that is taking place with a rotational component. And so whenever you see in the anterior to posterior plane, also you have to compensate for that and realize that there's changes happening in a right to left plane or the sagittal plane. Another etiology and causing effect of scoliosis in adults is osteopenia and osteoporosis. Women, especially over the age of 60, are disproportionately affected by this in relation to men. Another cause of this is sarcopenia, otherwise known as loss of muscle mass. As people after the age of 60 undergo a significant loss of muscles in the lower lumbar region, especially in the lower back. And you can see here an illustration of the different types of paraspinal muscles that are present there. This particularly is one of the causing agents of cervical thoracic deformity, where you can see this patient has a chin-on-chest deformity and has a difficulty of maintaining upward gaze. In terms of adult iatrogenic scoliosis, this is a scoliosis that develops after some form of medical or surgical intervention and really became prevalent after World War II when we began to treat idiopathic scoliosis in teenagers with Harrington rods. And you can see here in this illustration is a patient who was treated when they were younger with a Harrington rod, which did well in order to alleviate and stabilize their scoliosis, but also caused them to have a flat back deformity. This is another illustration of a patient with a Harrington rod that has undergone a correction and stabilization of their coronal deformity, but has led to a new deformity in the sagittal plane and a flat back scenario. This is a patient who underwent a surgery at an outside hospital for a degenerative spine process, which resulted in a flat back deformity, an anterior shift of the gravitational line forward in front of their pelvis, and required a wedge osteotomy for correction. What are the symptoms of spinal deformity? First and foremost are low back pain. This type of back pain is localized either to the mid to lower back region, will radiate into the buttocks and hamstring, but typically not past the knee. Other symptoms can include neurogenic claudication or radicular leg pain. Especially if there's a significant type of coronal curve and scoliosis, there can be entrapment of a nerve, which can lead to sciatica-like symptoms. How do we screen for this? During the visit, their thorough history needs to be taken as far as the intensity, duration, and location of one's pain. Also, a thorough prior surgical history and other types of medical comorbidities need to be assessed for, such as smoking, diabetes, osteoporosis, cardiovascular disease. Also, it is important to ask the patient about their activity level. How has this changed over the recent years? Then, a thorough radiographic exam needs to take place. In addition to regular films such as MRI and CTs, a DEXA scan is very important in the assessment of a patient, as are standing x-rays. Here at Hoag, I have a protocol with the radiology department that my patients obtain, which involves a x-ray that is taken from head all the way down to the feet. This allows me to see the patient's full alignment in space. Also, it allows me to see what their compensation mechanisms are. What are the treatments? First and foremost, we have to try with the non-surgical treatments. This surrounds itself mainly with physical therapy and activity. It is very important that throughout our age we continue to be active, not only for our bone health, but also for our muscle health. People who develop spinal deformities, typically due to the pain, will have a significant decrease in their activity level, which will be then a self-perpetuating spiral, which result in muscle atrophy and further degeneration of the muscles in the lower lumbar region. Therefore, it is important that these patients continue to be active in order to revitalize these muscles and strengthen them. Next are also pain injections, which are used throughout other types of spine pathologies. These type of injections can either be centered around epidural injections, facet blocks, or ablation procedures. Finally, what are the surgical treatments? Most importantly, when discussing surgery, it is important to determine what the goals of surgery are. Address the major pathology, discuss with the patient what type of curvature, what's the goal of correction of that curvature is, and first and foremost to prevent progression and recurrence or return to the OR. So let's take a little bit of time about discussing now some of the latest advances that this field has had in the past decade. I think one of the most exciting areas that has developed and has been made available to us as practitioners in the past decade is preoperative planning software. I use this particularly in my surgeries, and the people who work with me know that I'll spend sometimes upwards of 1 hour planning different types of procedures. We have different types of software that allow us to plan a patient's correction and also see what the alignment will be after that surgery. Augmented reality during surgery for placement of implants, along with navigation guidance, has also developed in the past decade and continues to do so. This also includes robotics, as are also physician-assisted navigation apparatuses. Artificial intelligence systems and predictive analytics has also recently been introduced and will continue to play a major role moving forward. Real-time neurological monitoring is, at this point, almost a standard of care in all types of surgeries such as this. Advances in spinal implants, new materials, are also have been moved forward significantly over the past years. Finally, the way that we approach each and every patient. Preoperative preparation is incredibly important. This stems from proper nutrition, cardiac conditioning, to physical strengthening, as we discussed previously. So let's go over some of these examples. So here you can see a slide which pertains to the GAP score. The GAP score was developed by the European Spine Study Group and allows one to enter the patient's spinal parameters, and a computer program will then tell you where this patient falls in terms of their alignment. You can see here that this particular patient has a severe disproportion. The max GAP score is a 12. 12 refers to the worst score that can be possible and the most severe type of disproportion. Then on the far right-hand side, you can see numbers that indicate to the surgeon what the optimal goals that are to be achieved in order for the patient to improve in their alignment. So this pertains to this particular patient who had a surgery at an outside institution. When he came to my clinic, you can see here that his parameters were entered into the preoperative planning software, and different numbers are available here. These angles refer to specific quality of life outcome scores that are correlated to functional outcomes. Next, I sat down with the patient and planned out their surgery with them and showed them what would happen depending on where the osteotomy was performed and how that alignment would look like. The blue line is what the computer model generates as the ideal spinal alignment that is to be obtained. And so you can see here, moving from the left-hand side to the right-hand side, depending on where the osteotomy is made for the correction, how the patient's spinal alignment will change. This is the preoperative film, and now we look at the postoperative film on the right-hand side after the surgery, where the patient had a wedge osteotomy performed, and we were able to obtain their optimal alignment. As such, we can now see the GAP score with the new ideal parameters that were entered in, and a GAP score of 0 indicating a proportional spine. Next, moving on to the augmented reality and intraoperative navigation. This is a 7D machine that uses non-ionizing radiation and allows for a complete analysis and augmented reality view of one's spine, and can be used during surgery in order to navigate spinal implants. This is the same type of technology that is used in self-driving vehicles. We can see here further intraoperative images from this type of technology, which is used to help navigate implants. I use this on every one of my surgeries at Hoag. Next here, we see an image from Surgical Theater, which is another type of augmented reality software. This here is a patient that has a thoracolumbar deformity. This allows us to exactly gain an appreciation of the extent of the deformity, the morphology of the bone, any other type of structures that are also important, such as vessels and nerves, and prepare the optimal surgery. This is the patient that the film pertains to, and we can see here the thoracolumbar deformity and the correction afterwards. Next is the advances in spinal implants. Over the past 10 years and moving forward, there has been great measure taken to customize and produce implants that are patient-specific. This is here an example, which is unit rods. These rods are based off of preoperative planning measurements and then customized to each and every individual. These materials also are continuing to evolve with different types of metals, where we started off initially with stainless steel, advancement into titanium, cobalt, and now there's further research ongoing with different types of alloys and even hybridization of metals. We see here a patient that these type of customized implants were used for before and after surgery. This was a patient who had a surgery at an outside institution and therefore underwent an iatrogenic-induced deformity, was unable to walk straight, and then we can see after the correction procedure following a surgery. This is the picture on the left-hand side. We can see the preoperative surgery that was done at the outside institution, and then this is after the surgery that the patient had here at Hoag, utilizing these type of patient-specific implants designed off of the preoperative planning. Next, as mentioned in the previous slide, was the neuromonitoring. Neuromonitoring is integral into these type of procedures. I use neuromonitoring on every one of my surgeries, and with the type of correction maneuvers that are performed in these surgeries wouldn't be possible. Here in this particular patient who underwent surgeries actually earlier this month, we can see a thoracolumbar deformity. When this type of deformity is derotated, one is monitoring the signals that are going through the spinal cord into the nerves. Any type of disruption of nerves tells the surgeon that they either have to hold off or change their approach. This allows for the patient, once the surgery is concluded, to not have any type of deficits and also not undergo any kind of unpleasant surprises. As far as future directions, it's equally exciting. Right now, there's active research that is ongoing as far as dynamic analysis that is being incorporated into the planning, meaning that we are taking a patient's gait prior to surgery, looking how they walk, and looking how this will be corrected after surgery. Artificial intelligence systems are continuing to be developed by different types of spine industry that will help us to determine what happens to the spine after surgery. As we know, the spine follows classical mechanic laws and most importantly Newton's third law. Whenever you alter the spine in any kind of way, the other spine that is not fused will also change with it. These AI systems are meant to tell us what those type of changes are and to avoid patients returning to the operating room. Analytics also will be able to tell us which patients are successful candidates to undergo these type of procedures and which are not. Furthermore, they'll be able to tell us what patients need to do in order to be classified as successful. Thank you very much for your time, and I'll go ahead and open it up to questions. One of the first questions we have here is, can scoliosis be exacerbated by sleeping positions? The answer to that is no. So scoliosis is a gravity-dependent type of phenomenon and therefore always is progressive when a patient is standing. When a patient is sitting or sleeping, the scoliosis doesn't progress. In childhood, this, however, is not the case. As a child continues to grow and develop, and as their bones haven't reached maturity, scoliosis can progress. Therefore, then we are treating pediatric scoliosis with the use of braces. Many times, these braces are indicated even during sleeping. All right, if there's any other further questions, please feel free to contact us and we'll get back to you with our answers. Thank you very much.